Ventricular septal defect. Isolated VSD is the most commonly encountered form of congenital heart disease in the pediatric population. This is not the case in the adult population for a number of reasons. Most children with hemodynamically significant defects are diagnosed and undergo repair in childhood because they develop signs and symptoms of LV enlargement and failure. Children growing up in developing countries often go undiagnosed and unrepaired well into adulthood because of absent or intermittent medical attention. Small unrepaired perimembranous or muscular VSDs often spontaneously decrease in size or close with age. However, small VSDs initially encountered in adulthood in patients older than 20 years of age are unlikely to close spontaneously. Large, non-restrictive defects that are not surgically corrected within the first 2 years of life result in incompletely reversible pulmonary vascular disease and are associated with increased mortality in childhood. Therefore, the spectrum of isolated residual VSD encountered in the adult patient usually consists of small restrictive defects or defects that have closed partially with time. The pulmonary vascular resistance is not significantly elevated and the left to right shunt magnitude is mild. QPQS ratio less than or equal to 1.5:1. The intensity of the precordial holosystolic murmur is inversely related to the size of the defect. Therefore, a disturbingly loud and harsh precordial holosystolic murmur in a patient with VSD should be viewed as a reassuring sign, not a cause for alarm. Large non-restrictive defects in cyanotic patients who have developed the Eisenmenger complex with systemic pulmonary vascular resistance and shunt reversal, that is right to left shunt. Patients with a moderately restrictive defect, that is QPQS ratio is 1.6 into 1 to less than 2 is to 1, who have not undergone closure for some reasons. These patients often have mild to moderate pulmonary hypertension. Patients who have had their defects closed in childhood, these patients may have small but generally inconsequential VSD patch leaks that may be identified by careful color and two-dimensional Doppler scanning of the entire interventricular septum during echocardiographic examination. Now, the natural history. Small restrictive defects of the muscular or membranous septum may be washed conservatively without the need for operative intervention. Patients are at increased risk for endocarditis as a result of the turbulent high velocity jet impinging on the septal leaflet of the tricuspid valve that partially closes many perimembranous defects. 6% of patients with small perimembranous defects may develop aortic valve prolapse and result in aortic regurgitation that may be progressive. The prolapsing aortic valve cusps, usually the right coronary cusp, may partially or completely close the VSD. Aortic valve repair or replacement may be necessary in patients with aortic regurgitation who develop exertional symptoms or progressive LV dilatation. In a long-term follow-up registry, the overall survival rate was 87% for all patients with unoperated VSD. For patients with small defects, that is QPQS ratio less than 1.5 and low pulmonary artery pressure, the survival rate was 96% at 25 years. Patients with moderate and large defects fare worse, with 25-year survival rates of 86% and 61% respectively. Those with cyanosis, that is Eisenmenger complex, had a much lower 25-year survival rate of 41.7%. In patients with large non-restrictive VSD, pulmonary vascular disease begins at or soon after birth with abnormal vascular remodeling. If the VSD is not surgically repaired, patients eventually develop obliterative pulmonary vascular disease. Systemic pulmonary vascular resistance results in a balanced bidirectional shunt or shunt reversal and cyanosis, a condition first described by Eisenmenger in 1897 and coined the Eisenmenger complex by Maud Abbott in 1927. Survival is generally decreased in these patients, although with proper medical care and protection against certain risks, example dehydration, endocarditis. Survivors have been reported into the 7th decade of life. Patients develop compensatory erythrocytosis, which is an appropriate response to the decreased systemic oxygen saturation from right to left shunting of deoxygenated blood. Phlebotomy is not warranted unless patients develop symptoms of hyperviscosity such as headache, visual changes that are refractory to hydration. As a matter of fact, routine phlebotomy does not reduce cerebral complications and leads to iron deficiency anemia. Microcytic iron deficient red blood cells carry less oxygen and are less deformable in the microcirculation than iron replete red blood cells, thus resulting in worsening cyanosis and increased cerebral complication, which are properly treated by judicious iron repletion. Now, management and results. Patients with small restrictive defects, that is QPQS ratio less than or equal to 1.5:1 and low pulmonary artery pressure are generally asymptomatic and should be managed conservatively and followed up regularly. Although antibiotics for endocarditis prophylaxis are no longer recommended by the ACC/AHA guidelines, patients are at increased risk for endocarditis. Patients should be instructed in dental and skin care. Small defects with aortic valve prolapse and aortic regurgitation may be repaired to avoid progressive aortic regurgitation. Larger defects may be repaired in the absence of severe pulmonary hypertension and severely elevated pulmonary vascular resistance, that is more than 10 Wood units into meter square, which incurs a high perioperative risk. Post-operative life expectancy is not normal but has improved over the past 50 years with improved surgical techniques and experience. Post-operative conduction defects are common, but complete heart block is rare in the current era. The post-operative risk of infective endocarditis is low. Transcatheter device occlusion of muscular and perimembranous VSD is feasible, and trials demonstrate a good safety and efficacy profile. Complete heart block has been noted to occur in up to 6% of children and 1% of adults. Thank you.